Well, good afternoon, everyone. My name is Echa Osara. I manage the research projects for the Health Resources and Services Administration grant with the Southeast Regional Newborn Screening and Genetics Collaborative. Part of our grant initiative is to host some of these Lunch and Learn seminars, and the goal is to highlight key experts and their research within human genetics. So I'm going to go ahead and hand over to Emily Lisi. She's the co-chair of the Workforce Capacity with SERC, and she'll be introducing our speaker today. Thank you all for coming.
Okay, so I'm going to introduce Stephanie DeArmey. So she graduated from the Physician Assistant Program. Is this echoing a little bit? Okay, do you want me to stop? Testing. Better? I pulled it down a little bit too. Okay. So she graduated from the Physician Assistant Program at Duke University in 1999 and joined the Duke Pediatric Medical Genetics Program in 2001. She's worked closely with patients and families with metabolic disorders, including lysosomal storage diseases, glycogen storage diseases, and other rare diseases. She's worked in both the research and clinical arenas, specializing in coordinating a multidisciplinary approach and providing continuity of care to patients with complex medical needs. She serves as the research lead for the Duke Medical Genetics Research Program, and she's going to talk to us today about Pompe disease. She has quite a bit of experience with Pompe disease, both in the clinical and research arena at Duke, and specifically about newborn screening for Pompe disease, which will be starting hopefully in the very near future here in Georgia. So thank you for coming.
Yep. Come on. Thank you very much for having me today. Is the sound okay? Okay. Right. So we are going to talk about Pompe disease. And first I wanted to check to see who's in the audience today. So who is involved with LSDs and knows about Pompe disease? Has been involved with treatment of Pompe disease? Okay. Who knows nothing about Pompe disease? Okay. All right. Who is lab people? Okay, and for those that didn't even raise your hand, what are other options? Dietitian? Okay. Public health students? Anything else? Did I miss anything? Okay. So here's my disclosures. And first I want to acknowledge the group we have at Duke. It really is a team effort with both clinical and research that we do at Duke. Am I okay? All right. Dr. Kishnani, I have the pleasure of working with her. She is an expert in this field. If you do any research on PubMed, search her name, there's, I think, 5,000 articles by her. So I am lucky I have the expert right at my fingertips. My office is right next door to hers, which can be good and bad. She knocks on my door quite often, asks me to do things, but it is a group effort. So if I can't answer your question today, I know some people that can. I am not the expert. I'm a physician assistant. I trained in general program. I have been with Duke for 14 and a half years, worked with Pompe disease since I started working. So I have a lot of clinical experience with them, a lot of research experience, but I don't claim to be the expert. So like I said, if I can't answer your question, I'm happy to find the answer for you. So a little bit about Pompe disease. It is a rare autosomal recessive disorder. It's been reported to be 1 in 40,000 births, caused by low enzyme called acid alpha-glucosidase. There is a wide spectrum of the disease severity, depending on the degree of enzyme that's made by the patient. Early onset or infantile Pompe disease can be caused by the complete deficiency of the enzyme. It's been reported that symptoms begin in the first year of life. Many of the symptoms that you'll see, muscle weakness, feeding issues, poor weight gain, head lag, breathing difficulties, and if untreated, the natural history studies report that usually they'll die within the first year of life. For later onset, juvenile as well as adult Pompe disease, they do have partial deficiency of the enzyme, so they do make some enzyme. Symptoms can begin as early as the first decade of life. I think the latest that's been reported is in their 60s. Primary symptoms that we see, muscle weakness, especially proximal and the trunk weakness, leads to respiratory weakness. So most of the patients that will succumb to the Pompe disease, it's from respiratory involvement. Here are some videos of our patients. So basically, treatment initiation can begin at different stages depending on when they're diagnosed. Here on the left, early diagnosis, pre or early symptoms. You can see he's running, but still with some weakness. You can see he's not quite running like a normal kid. Here you can see some symptoms. He's sitting with help. He's kind of weak. You can see he's not moving. I don't think I can make this move anymore, but if you saw this one, he can't really get up from a sitting position. And in this, for this patient, he was 18 months when we saw him at Duke. You can see he can move his hands a little bit. He can wave. He can shake his head. And then here, after a year of treatment, he can barely move his hand at this point. So we know that at this point there's been some irreversible damage. So for the later onset, again, the treatment can be started at various stages. Here on the left, you have a young girl who very little or pre-symptomatic, is very strong. Wait, is this moving? There we go. So in the middle, this lady is having a hard time walking without the support. Here after treatment, she's working more confidently without support. Here's a man that started treatment after irreversible damage was noted, and you can see he's having a very hard time getting up from a supine position. So with enzyme treatment of Pompe disease, what factors affect the outcome of the patients? Why is there such a wide variety of how patients respond to the treatment? Early initiation is really one of the main things that we've identified to affect how well treatment works. And along with early initiation, what is the extent of muscle involvement at the beginning? There's been some studies that are done regarding muscle fiber type. Type 2 versus type 1. Type 2 have fewer mannose-6-phosphate receptors, which is the receptors that the enzyme lumazyme hooks up to. And so we think the enzyme doesn't get to those muscles as readily as type 1 fibers. CRIM status, cross-reactive immune material status, we'll talk more about that in a little bit. So we know that the CRIM negatives in general can produce high antibody titers, sustained titers, which can affect the efficacy of the enzyme, and other modifiers that we're learning about still, such as ACE genotype. And if anyone has any questions, feel free to interrupt. I don't mind. Here is a child that started treatment at 2 weeks of age. And you can see, I'll get all the videos running, throughout, oh, nope, I can't do it now. So 2 weeks, here at 3 months, very energetic little 3-month-old. He's kicking, he's very active. Here at 2 years, he is walking, running, full of energy. And then, I don't know if I can get 7. I can't get the 7 to work, but he's running at age 7 as well. So a good responder, what we call as a good responder to the enzyme. So here's a look at the muscle. So what's going on in the muscle at baseline has a lot to do with how they respond, what the motor response is going to be. Here's a picture of a muscle. It's kind of hard to see, but the glycogen is membrane bound and within the lysosomes. Here is a muscle where the lysosome membranes have broken down and glycogen is in the cytoplasm. I have another slide. I think it's a little easier to see. This is pre-treatment. The blue is normal muscle. The purple is glycogen. This is a baby that was not as affected pre-treatment. So you can see a lot of blue with scattered purple going on. Still some nice organized muscle cells here. In this patient, pre-treatment, lots of purple, lots of glycogen spread all throughout the muscle fiber. So it's spilled into the cytoplasm. Post-treatment, this is 6 months post-treatment for this patient. Nice striated muscle cells with a little bit of glycogen in there, but all nicely within the lysosome and cytoplasm. Here, after 12 months of treatment, you can see the enzyme really hasn't had much effect on the muscle. So lots of purple scattered. You can't see much blue. And so we know that that muscle is not going to respond as well to the enzyme. And just one little caveat. So the muscle biopsies is just a small snapshot of what's going on in that particular patient. We found that we can do 2 muscle biopsies in the quad right next to each other and have totally different histology reports. Right next to each other, this could have easily been from the same patient. There can be that much discrepancy between the muscles. So whenever you see a report of muscle, you do have to compare it with the clinical presentation of that patient. You can't just base it on this. Crim positive versus crim negative. So does anyone here not know what crim positive versus negative is? Okay, all right. So this has been a very hot topic in the Pompe world for the last 8 to 10, 12, 15 years. Essentially, in the first study in 1999, the first baby study, there were 3 patients. And 2 of them didn't respond well. 2 of them, they had cardiac improvement, but skeletal muscle didn't have really any improvement at all and ended up ventilated. 1 patient responded well. I have a picture of him later. What was the difference between that 1 patient and the 2 patients? So we figured out the 2 that didn't respond well were crim negative. The 1 that did respond well was crim positive. And a lot has been studied since then. So crim positive does make some of the enzyme. It may be functioning or non-functioning. So even though they have some in their body, it may not be enough or working well enough to do its job, which is to get rid of the glycogen that's storing up in the muscles. But what does happen is the residual enzyme allows the immune system to recognize the recombinant form of the enzyme, which is the lumazyme, which we're giving them as a treatment, to recognize it as self. And so usually we have low antibody titers. There are some patients that have developed higher antibody titers to the enzyme. So we do know that the crim positives can have good clinical support response. There are some that have poor, and we're still trying to tease out a lot of that. With the crim negative, so they have no form of the enzyme in their body whatsoever. So when you administer the lumazyme, it doesn't recognize it as self. So the body immune system makes these high antibody titers. And we found that the high antibody titers interferes with the efficacy of the enzyme and thus a poor response to the enzyme. And of course, there are people that don't fall into this category, patients, and 2 of them are here at Emory. So these are, in general, there will always be outliers. So let's see. So from this paper, you can see how the difference is in the titers. After 64 weeks of treatment, the crim negatives, 4 of them reported going up to over 400,000, whereas the crim positives are at about 300. So quite a big difference. And at this Kaplan-Meier survival, the solid line is the crim positive, and they're surviving well past 80 months, whereas the crim negatives, most of them are not surviving past 20 months. Like I said, there's a subset of crim positives also that do develop the antibody titers and have a similar outcome to the crim negatives. So here you can see the red dotted line is the high titer crim positive patients. So they're following the same path as the crim negatives. So there's been a lot that's been published. You can read up on that. There's a lot of articles out there. You can talk to your clinical team here who have had a lot of experience with this as well. Here are 2 of the babies I was talking about from the first study. This is the crim negative on top, crim positive on bottom. Crim negative did start a little bit later, 4 months versus 2.5 months. You can see after 9 months of treatment, poor response to therapy. He's vented. He has very little movement of his hands. He's not moving his arms. You can see his toes and feet moving just a little bit. Whereas this guy at 13 years, he was throwing the ball, he was running. If you watched him, he does have some deficit, but he was running, walking. You wouldn't, if you saw him walking on the street, you wouldn't say, oh, there's a guy with Pompe disease. And we'll talk about this later, but we're still learning about these survivors as well. So there are some limitations to the therapies that are available for our LSDs. So the delayed diagnosis does limit the impact of the treatment, does it cross the blood-brain barrier. But with all of them, there are all of these limitations. Pompe especially, arrhythmia risk despite enzyme treatment, irreversible muscle damage. In autopsy, we see anterior horn cell disease and bulbar involvement. So the enzyme's not perfect. It's not getting to everywhere that we need it to be. With a arrhythmia risk, there should be some papers coming out on that soon, but there's a thought, we have some patients that, so the infantiles have these huge hearts, cardiomyopathy and left ventricular hypertrophy, and there's a remodeling that happens with the enzyme. So the hearts get better, they get smaller, the function improves. But we're still wondering, we don't see anything on EKG, we don't see anything on a Holter, we don't see anything on echo. These kids are now 8, 9, 10, 11, 12 years old. But clinically what we've seen is some deaths. You guys treated one patient nearby here. Is it because of cardiac arrest, something to do with the remodeling, something's still going on? We don't know. So we're still investigating. We still follow our patients, the older patients closely that have no cardiac involvement. We follow them still annually with our cardiologists with echoes and EKGs and make sure that they're not lost to follow-up in that aspect. So as we bring it back to newborn screening, with the newborn screening, we hope that we can initiate earlier treatment. But will it prevent some of these long-term issues? So let's look at some of the data that's available. This is a map that's fairly up to date. I got from Dr. Kishnani. So the red states have rejected legislation on newborn screening for LSDs, or it's been greater than 1 year. So my state is one of them. The gray states, they're currently reviewing legislation. The yellow states have passed, but pilot programs have not begun. And blues have sponsored pilot studies. And the green, which it's growing, have either implemented a program via pilot or regular screening. So I was just talking to Emily earlier. So Georgia's one of them. So they have an NIH grant, but there have been some challenges. So you guys know more about those challenges than I do. So I'm not going to get into that. If you want to talk about it later, we can. So for LSDs in general, let's look specifically at Pompe disease. So prior to newborn screening, we did think the incidence is 1 in 40,000 births. We do have literature that says it presents in the first few months of life. And we still know that, of course, it's a spectrum of disease for the juvenile and late onset. So here are some videos. We know that infantile onset is very rapidly progressive. You can see can't sit independently, having a hard time with head control. Here's significant head lag. This baby is significantly hypotonic and weak. It's being fed by a G-tube. And here you can see a nice picture of a normal heart versus a child with Pompe disease, and this is a silhouette of the heart. Okay. So with infantile Pompe disease, it's been reported that The median age at symptom onset is 2 months. The median age of diagnosis is 4.6 months. So even if you have a patient that's presenting like the patients we saw before, there's still a delay. The median is 1.4 months, but there's still a delay between diagnosis and symptom onset. And then there's also going to be a slight delay between diagnosis and treatment. So we got to figure out how to improve this. These are some of the symptoms that they present with: respiratory, musculoskeletal. So there are certainly signs and symptoms that are being reported, but we still have that delay. For those that are treated, once we do start treatment on those after that delay, we still are seeing issues come up. We kind of mentioned a little bit this before. Some of the emerging phenotype in the infantiles that we're treating. Cardiac, we talked about cardiac arrhythmias. We've seen some dilations of the aorta. Is there fibrosis going on? We did some cardiac MRIs to look at this. So there's still some ongoing studies about that. From a neurologic perspective, hearing loss, like I talked about, anterior horn cell involvement, bulbar involvement, and white matter changes. These are seen on autopsy. So we know it's not crossing the blood-brain barrier, so are we finding some neurological involvement? We have done developmental testing on a lot of our patients. We find that they are of normal intelligence. I think there have been some reports that there is some below average intelligence with some of these patients, and that's has not been published. I know specifically I attended a talk and someone presented that without any supporting data. So from what we know, there is no intellectual delay with these patients. Speech, hypernasality is very apparent in some of our patients. And I have a slide coming up. I don't know, didn't hear any volume, so I don't know if that's going to be playing. I don't know if she's listening to me. But that's later on. And then eye findings. We're finding lightosis as well as severe myopia and sphincter issues as well. So this data is obtained from our long-term survivors who were started early on treatment and have responded well, but still, obviously, we need to figure out how to do better. With the juvenile or atypical, we're not doing any better. We're doing worse. Their typical age of symptom onset is about 6 years old, but the median age of diagnosis is 18 and a half years old. So it's still 12 and a half year gap is the median between symptom onset and diagnosis. So that's really significant. There's a lot of muscle damage that can occur during that time. You see the presentation's a little different, not as much, more of the respiratory, less of the musculoskeletal. So here are some of our later onset patients, and you can see that they are a little bit stronger, a little bit different presentation, still head lag. You can see this little guy has that same trunk weakness, that lordosis, that classic late onset Pompe walk. He looks like one of the older gentlemen that you may see in clinic. And did you see this girl? She was walking. I don't know if you saw her. And this little boy, he can sit independently, but you can still see he's significantly hypotonic. You can see the open mouth. And this guy, I don't know if you notice, he is trached, but he still has a lot of movement, able to use his upper and lower extremities. So here's one of our later onset patients. She's very strong. If you saw her, this was the girl that was walking earlier. If you saw her in clinic, you might not think she has any signs or symptoms of Pompe disease. She's able to do this without any problem. But we did a whole body MRI. This is under research. And what it shows us is the percent of fat infiltration in her muscles. We've broken it down to muscle groups. And you can see in her quadriceps, it's actually up to 45% of fat infiltration. So that's not normal. That's really high. Almost all of her muscles are somewhat affected. Even her bulbar here, the tongue and the swallow are severely affected. So this data is being, I'm not sure if it's I think it may be I think it's been published. So if you want to look up what the data is, if you look up whole body MRI and Pompe and Kishnani, you'll see there's actually this is a really good way to see how your muscles are being affected by enzyme treatment and where the weaknesses are. We've learned a lot about the bulbar weakness and the lingual weakness through that. Once again, earlier treatment versus later treatment. We keep emphasizing this because this is why newborn screening is occurring. Early treatment has such a better outcome. And I can't emphasize that enough. Here on the left, she started treatment at 6 months. This guy is the same guy you've seen before. He started at 2 weeks. So the girl's not playing. Let's see. Okay, well, can't see the girl, but you can see she's on this trike that with support, and here she has braces. She can't bear weight on her own, and she needs the support to stand. Whereas this guy, running, walking, jumping, doing quite well. All right, this is where I need sound. I don't know if I can get it. So this is the sound that I wanted to play. So not the hypernasal treatment. Listen to this. Shoot. Can I get her to talk? I can't. It's not doing it. I can't click on her. Can I click on her here? Too bad. Okay. Do you want to turn the volume part off now? All right, sorry about that. If you could hear her speak, she has significant hypernasality. Has anyone in the audience heard that hypernasal Pompe speech? So it's hard, it's difficult to understand. It's, and we think it's from the lingual weakness. Their palate is not as strong, it's lower. There's been some work with palatal lifts with these patients, and from what I've heard, these patients are young, so it hasn't been successful at this point, but we see the later treated patients having that involvement versus the earlier treated patients not having that involvement. So newborn screening for Pompe disease. So it has been initiated throughout the world in some areas, Taiwan, Japan, Austria, Hungary, Germany, and in some states in the US. So it's getting out there. It is expanding, which is good. The enzyme activity is measured in dried blood spot. There are different assays and different ways to measure. It does not distinguish between infantile onset and late onset. It can detect carriers, and it may detect late onset with no phenotype. And there are pseudodeficiency alleles that have been identified. A little bit about that. So pseudodeficiency was not really understood at all or even presented until newborn screening. So what that is there's patients that are screened for Pompe disease, and they show a reduction in GA activity in these assays. But really, they're otherwise healthy individuals or carriers. So if you do molecular testing, they have these alleles, and there's no reports that these alleles are associated with Pompe disease at all. So the GA activity in the homozygotes with this allele are comparable to those affected with Pompe disease. So we look at it, and we see this low enzyme level, and we see these as a result, but they don't look like a patient with Pompe disease. So you have to start thinking, is this a pseudodeficiency allele? Up to 4% of the Japanese population, it's reported as homozygous for these mutations. Right now, we believe it's rare in European African populations, but perhaps with expanding newborn screening, we're going to find otherwise. We're always learning different things. And in the Missouri data, Pacific Islanders did have this allele present. So a little bit of data from the Taiwan group. So they, I don't remember when they actually started newborn screening, but they're the ones with the most data published at this point. So there's a lot we can learn from them. So one thing we definitely learned is newborn screening has led to earlier diagnosis, which is the whole goal of newborn screening. Median of 22 days versus 3.6 months, and improved survival. So this is really significant data, I think. Those through screening, 100% of them at age 2 years are event-free survival. So as we saw with the natural history, as we discussed with the natural history, this is not what you expect from patients with Pompe disease and treated Pompe disease. There were 9 that were clinically detected. 89% of them were survived at age 2 years, and only 67% of them had event-free survival. So these numbers are really telltale that newborn screening is improving the outcome of these patients. For the later onset, so early detection and early treatment initiation. So the mean delay from onset of symptoms to diagnosis averages 10 years. Newborn screening has found to be to help earlier detection and help to retain normal motor function. So this is a big discussion that will continue. When do you treat these later onset patients that are found on newborn screening? In Taiwan, 13 out of 344,000 were found to have later onset Pompe. This is just a quick look at the incidence, comparing what's been published. This was published by Awesom's paper, and one of the places where we get the 1 in 40,000 incidence. But for the data from Taiwan, we now see that 1 in 18,000, specifically in the Taiwan data. Okay, so I think this is a misplaced slide. This is late onset Pompe disease. So I think some people may question, what's the urgency of treating these patients, because they are surviving, they're not dying early like the infantile onset. But you can see it's severely debilitating and it's progressive. Here's a patient, pre-treatment, you can see that she is able to get off the floor. Here, even after initiation of enzyme, she is not able to get up off the floor. She can't do it independently. So significantly affecting their lives. Here, data is available that after 15 years of Pompe disease since onset of symptoms, over 60% are non-ambulatory in some sense because they're in a wheelchair, and about 60% also have some type of respiratory support. So I did not want to share all the data that's out there from University of Washington and Taiwan, but this is a summary slide that has shown how much the incidences have changed. University of Washington reports 1 in 27,800. Missouri reports 1 in 11,375. Taiwan, like I said, 1 in about 17,000. So these numbers are significantly lower than was previously reported. And I believe we're going to get a lot more data from all the states that are going to be doing newborn screening, and it'll be interesting to see, are we going to, what is the incidence? Is it really going to be closer to 1 in 10,000? I don't know. It's a rare disease. You're dealing with small numbers. 4 cases were found in this study. Missouri reports 12, and Taiwan reports 28. So after newborn screening, we now know that the incidence is much higher than we thought. Infantile onset Pompe disease presents in the first few days of life versus what we thought within the first year of life. So we can treat earlier, but we still have some residual disease. So still a lot left to help these patients have a better outcome. We've learned a lot about the pseudodeficiency alleles, and for juvenile and adult onset patients, there's still the questions about treatment. Some of these patients have no phenotype. They won't present with any symptoms ever. How do we determine that? We don't have enough information about those mutations to say that we can predict this. So that will continue to be a question. So what have we learned from what's been reported from Taiwan? Again, higher incidence than we thought. They have all CRIM positive patients in Taiwan. They don't report any CRIM negative. So when you're extrapolating that data from Taiwan, you got to consider they don't have any CRIM negative patients. The late onset patients in genotype are unique and different. There's no splice site mutations in Taiwan. So there's some things in common, some things different. So you have to take what applies to us in the US. Carriers, we found patients, well, Taiwan has, that may have low GA enzyme activity level, and they are identified through screening, but they're actually carriers and they don't actually have the disease. And then we talked about pseudodeficiency. So when to initiate treatment, that's what we're talking about. So you've found them on newborn screening. What do you do with them? We know with the infantile onset, especially with cardiomyopathy, but any infantile onset patient, you want to begin treatment as soon as possible. We know it improves the outcomes. We'll use mutation analysis. You can predict the CRIM status. So we found that 92% of the cases we can predict from mutation analysis. And if late onset, ERT to begin based on various factors. So all these are still down here for later onset are questions. Luckily, there are guidelines being developed for this with the international working group. So I think as you guys start doing newborn screening, I think this is going to be published soon. This hopefully will help you in your guidelines on how to treat these patients. So the questions raised again, the varying allele frequencies, the Taiwan data, you can't predict those in the US. These different phenotypes and late onset, a lot of different things to consider and how are they going to be managed. And then again, the treatment initiation for the later onset, clinical involvement, molecular status, signs or symptoms or both. We don't really have guidelines to tell us how or when to start treatment. Genetic counseling in newborn cases is going to be really important. All of these things are going to come up as patients are identified, as families are contacted. Missouri has had a lot of published data on this. And here are some of the challenges. Again, we talked about communication with the parents, unknown onset, unknown risk. There's a lot we don't know. We know that your baby has low enzyme activity. We don't really know anything beyond that. Try talking to a new mom about that. Lots of unknowns. Testing of unaffected siblings for variants of unknown risk. So I don't have this in my slide set, but we had a affected patient who was about 4 or 5 years old. Later that same year, mom presented with symptoms, found out she wasn't a carrier. She actually has late onset Pompe disease. Other siblings were tested. Two of the siblings have late onset Pompe disease. So I think this is going to be a huge thing as we identify more patients with this disease. Again, as we talked about before, pseudodeficiency in carriers, following those patients and explaining what that means, that they have a pseudodeficiency in a carrier. And then how are you going to follow up with these patients? I think that's going to be a challenge. You identify these late onset patients. They don't have any symptoms. They're a fine little baby. They're growing. They're meeting all their milestones. They grow up. Maybe you follow them as a kid. They grow up. They go to college, and you lose them. They don't think they have anything. What's going to happen to them? So those are all issues, I think, that are going to come up. So this is the working group that I was talking about. So they met in 2014 in June. They are publishing guidelines, And Dr. Kishnani said it should be this year. So these are the members on it. A lot of the experts worldwide with Pompe disease. So keep an eye out for these. Read these papers. Contact these people. I'm sure most of you that are involved with treating these diseases know most of these people. They are great contacts. They will help you kind of figure out your own system as you guys start the newborn screening. So really, this is where all the gratitude really falls on. These are some of our infantile and later onset patients. We have a meeting for them almost, is it annually? We've done it for the past several years. We have a patient meeting for late onset as well. But this is what keeps us going. This is one of your babies that unfortunately did not survive. And thank you for allowing us to be a part of his care. Some of these kids have grown up and we found succumbed to the cardiac arrhythmias, we think. This is the oldest living survivor of infantile onset Pompe disease. He is 16. He is driving. He has manual controls because we didn't see him, I think we saw him when he was about 10 years old, and then we didn't see him again until he was about 14. And during that time span, he went from ambulating independently to being in a wheelchair. It's very sad, very emotional. What are we doing wrong? Why was he ambulating and not now? Puberty, we think, has a big part of it, and we're working on publishing some data from that. Increased metabolic needs. We're not giving him enough enzyme to get to his muscles. So he has since increased his dose. 20 milligrams per kilogram every other week is the package insert for Lumazyme. A lot of these patients now are getting a lot more than that, up to 40 milligrams per kilogram weekly. And I think that's the highest that we're dosing. I believe there's some publications that are even higher than that. So he's improving, but we hope that some of the damage that was done between those years, he'll have some improvement, but we don't know. This little girl, she's one of our patients that was in a study in 2003. And so she is about 12 years old as well. Also, we report her as a good responder, ambulating, doing well, and then recently seen in clinic with a lot of decline. Not walking, severe scoliosis, causing problems with breathing. She was about 6 months when she started treatment. So there's so much to learn, is basically my take-home point. These kids have survived, for the most part, they've all survived past the 1-year mark, which natural history studies say they shouldn't have. So we have enzyme. So we're helping them there, but how can we help them more? We hope newborn screening, starting them early with treatment, can help with that. For those of you that don't get to see these patients or working in a lab or working in some other area with newborn screening, these are the patients that you're helping. And I think that's what you got to keep in mind. It's probably going to be a difficult process getting it in place, is what I've heard if I've talked to the other institutions. But if we can improve the quality of life and extend the lives of these patients, then I think it's worth it. So thank you very much. Any questions at all?
So based on your observations with your kids hitting puberty, are you guys upping the dose of enzyme preemptively for your kiddos as they're aging?
We're basing it on assessments that we were doing on these patients. So for the ones that patients that come to see us, we do physical therapy evaluations on them at least annually, if not more often. And if we start to see a decline, then we will start to increase enzymes. So for many of our patients, can I turn this off? Am I done with the web? She's not paying attention. We do increase it early, pre-puberty. Yes?
Have you increased it in anyone who's had high sustained antibodies? Who's adopted their antibodies?
We have not. So that's a tricky situation.
I'll let you know it.
Yeah. Yes. The cost for therapy? It's expensive. Lumazyme comes in 50 milligram vials. It is, I've been told that the base cost is about $500 a vial. I know there's significant markup at Duke. Turns into, for one of these babies, up to $50,000 per infusion. For the adults who get a much larger dose, because it's based on weight, hundreds of thousands of dollars per infusion.
How do families cope with that cost?
So up to now, Genzyme is the only company that makes the drug. There are other drugs that are being studied right now. They have a great case management group. They have helped patients that have reached their max on their insurance. So I don't think there are a lot of patients that have had to do a lot out of pocket. You know, to pay $100,000 every other week is pretty much impossible for most of the U.S. population.
Most of our patients don't pay anything, actually. If
Yeah.
Genzyme will pay, like, has put this program, but that's what it is.
So luckily, Genzyme has really been helpful in that aspect. Yes?
For the pseudodeficiency folks that don't present with Pompe, have you observed a different phenotype? Are they presenting with the phenotype, or is that been?
They haven't presented with any phenotype. I know of one specific case, the baby had something going on. This wasn't on newborn screening. It was just they were screening for some sort of diagnosis. Didn't really present as Pompe disease. I think had some heart involvement, so they just tested for Pompe, and they came up with these with low activity. So they thought, oh, this is Pompe, but really didn't look like Pompe. But in general, no specific phenotype.
We're streaming this live online right now. We have 11 participants viewing via WebEx. Do any of you, the WebEx participants, have questions?
No? Okay. If everyone can please complete the post-test and return them here before you leave, that would be great. Thank you so much, Stephanie.
Thank you.